So thank you so much for the opportunity to present my work today. And I'm going to be primarily talking about the trends that we're observing in mental health among US adolescents and how we're going about trying to think through what the etiological drivers are that are underlying these trends and how it's really forcing me as a psychiatric epidemiologist to rethink how I'm thinking about risk factors and prevention and hopefully, engage in some discussion about how these results might apply to Australian adolescents and how we are thinking about adolescence more generally. So in the US, mental health among young people is truly facing a crisis. And I'll show you some examples that are really converging and showing increased depression, mood disorders, and suicidality among adolescents and young adults. These are data from Monitoring the Future, which is a yearly cross-sectional survey that we do of secondary school students in the United States. It's nationally representative. And each of those, this trend line is the mean depressive affect, which are a series of depressive symptoms indicative of mood disorder from 1991 through 2018. And the boys are the black line and the lighter line is girls. And depressive affect was generally declining throughout much of the 1990s. And around 2009, 2010, a change occurred and depressive affect has started going up. It's now higher among US adolescents than it has been in any year that we've ever measured them in Monitoring the Future. This rapid increase started earlier for girls than boys, and the slope of the increase is faster for girls compared with boys. A completely independent survey in the United States is the YRBS, the Youth Risk Behavior Surveillance Survey, which biannually conducts a nationally representative sample of U.S. adolescents, but again, completely independent from Monitoring the Future. And in that sample, they include a series of questions examining suicidal behavior, including suicidal ideation, which is this red line in the top, suicide, making a plan for suicide, which is the kind of purple line, suicide attempts, and the black line down below is suicide attempts such that it required medical attention, serious enough to require medical attention. And very similar to Monitoring the Future, a completely independent survey, for these more prevalent symptoms of ideation and making a plan for suicide, it was declining through much of the 1990s. The axis here goes from 1991 through 2019, so this is last year's data. And very similarly to Monitoring the Future, right around 2009, 2010, a change occurred and suicidal ideation and making a plan started to increase. You actually see a similar trend for attempts and injuries, but because they're more rare, you can't see the change as abruptly as for these other more prevalent suicidal behaviors. You can also see the exact same change at the exact same time for emergency department visits for suicide attempts and suicidal ideation and self-injury. Shown here in the green line is the time trend from 2007 to 2015 in all pediatric emergency department visits total. And you can see that it's pretty flat. There really hasn't been much change in the total number of kids who are going to an emergency department. But what has increased is emergency department visits that are coded for suicide attempt, ideation, and self-injury, which again, really started changing right around 2010 is when you started to see that increase occur. Unfortunately, we're also seeing the same trend at the same time for suicide death among adolescents in the US. These are the trends in suicide death for adolescents aged 15 to 19, and very similar for girls, for example. Suicide death, the slope significantly changed in 2010 and started rapidly increasing. For boys, similar to what we saw in Monitoring the Future and what we've seen in other data sets, the increase starts a little bit later, but boys are increasing in terms of fatal suicide death as well. And I should note that these axes are different. Boys have a much higher rate of fatal suicide death compared to girls. So this axis goes from 0 to 6 per 100,000, and this is 0 to 20 per 100,000. So boys remain about 3 times more likely to die by suicide compared to girls, but both of them are increasing at relatively rapid rates. We're not expecting any good news to occur in these trends because of COVID. This is a survey that was done by the CDC from June 24th to June 30th, asking, it was a nationally representative survey of all ages, asking people about mental health problems during COVID. And what you can see here is that depressive and anxiety disorders, the red bars for young adults, this is 18 to 24, upwards of 60% of young people in the United States had significant anxiety and depressive symptoms. When you look at, I can't see this very well, seriously considering suicide in the last 30 days, almost 1 in 4 young people in the United States in June of that year reported seriously considering suicide in the past 30 days. And while this survey was done during COVID, they took these results and compared it to a similarly conducted survey done the previous year, the BRFSS. It's a nationally representative survey. And so, for example, the prevalence of anxiety disorder was approximately 3 times that reported in the second quarter of 2019, so the same time period. And depressive disorders are approximately 4 times those reported in the second quarter of 2019. Now, there are methodological differences between these two surveys, so I don't think the comparison is totally apples to apples. It's a little bit apples to orange. But certainly, we don't think that these trends are going to have any good news due to the pandemic. So, because of these trends, obviously, the attention of psychiatric epidemiologists and certainly those who study adolescents has been squarely put on, why? What's going on? What happened in 2009, 2010 that has explained these patterns? And when you talk to anyone, parents, layperson, researcher, anyone about this, they say, well, it has to be the smartphones, right? Have smartphones destroyed a generation? This is the major explanation that people put forward. And, I would love to give a full talk about the research into smartphones and digital media and their association with psychiatric symptoms, but that would require a lot more time. Suffice to say, it's certainly a complicated story. And thus far, there really has been no compelling evidence that screen time and smartphone use, in particular for adolescents, is driving the increase in depressive symptoms. There was just a meta-analysis and review that just came out a few weeks ago, actually a few months ago now. Time has no meaning anymore, as we all know. And we contributed to this a little bit. I'll just highlight our work in Monitoring the Future, where we have for the past decade been measuring social media exposure and depressive symptoms in the United States. So this is 2009 to 2017. On the top half of the slide is the relationship between daily social media use and depressive symptoms among girls. And on the bottom half is the relationship between daily social media use and depressive symptoms among boys, stratified by the adolescent's propensity to have depressive symptoms. And this is really the key limitation that drives a lot of the research, is that adolescents who have mental health problems use their smartphones and use social media really differently. And so actually, once you stratify by an adolescent's propensity to have depressive symptoms, there really is no association between the amount of social media use that adolescents use and depressive symptoms. So among girls, for example, here's the odds ratios for the relationship between daily social media use and depressive symptoms at various different cut scores, increasing the threshold for high depressive symptoms by more and more and more. And there's absolutely no association. Among boys, at the high cut scores, using a lot of social media is actually protective. It's in an inverse association. So certainly there's no signal in our data for an increased risk of depressive symptoms given a high degree of social media use. And that is consistent with now a wealth of accumulating data, to the point that finally the New York Times said, panicking about your kids' phones? New research says don't. And this is particularly good news during the pandemic, as parents are increasingly grappling with new limits or no limits on screen time and how that potentially affects their adolescents' mental health. So because screen time and social media use has really, quite frankly, been pretty much a dead end for at least our research program, we've tried to think more broadly about other things that are changing among adolescents. So we've gone down a whole rabbit hole of different ways that adolescents are engaging with the world around them. So for example, we've been doing research into religious service attendance and importance. And what we see in the United States, and was shown here in the red bar, is that the percentage of adolescents who attend religious services is declining, and the percentage of adolescents who report that religion is not important to their lives is increasing. Or conversely, the percentage of adolescents who report that religion is salient to their lives is decreasing. At the same time, depressive symptoms are increasing. You're seeing this whole shift that started before the depressive symptoms started increasing, is this decline in religious affiliation, attendance, and service. And we actually see it across many different denominations as well. Just increasingly, US adolescents are becoming less religious and attending services less. And essentially what we did is we projected what we would have seen in terms of depressive symptoms from 1991 to 2019 if religious service attendance and the salience of religion to adolescents' lives had remained the same as it was in 1991, if it hadn't declined. And essentially, so that's what is shown here. The blue line is what we observe. The red line is what we would have observed if we had been able to freeze time and keep religious service attendance and religious importance what it was in 1991. And we can explain about a third of the increase in depressive symptoms through the decline in religious service attendance and salience. We've also looked at other risk factors that are changing over time, such as sleep duration. We've been looking at this and monitoring the future for a long time. Sleep duration among US adolescents has been declining for about 25 years, pretty steadily. So for example, this is the proportion of adolescents who get 7 or more hours of sleep. The American Academy of Pediatrics actually recommends 9 or more hours of sleep. We measure 7 or more hours of sleep in monitoring the future. And it's well under half of adolescents that are getting 7 or more hours of sleep in the United States. And that's been declining again for about 25 or 30 years. And essentially, if you look at the sort of the period effect in depressive symptoms, so the amount of the variation in depressive symptoms that's changing across all adolescents across time, that's shown here in the blue, this big increase starting in 2010 that we observed. And the red is the amount of the period effect that it remains after controlling for changes in adolescent sleep. And it's actually completely explains the period effect in depressive symptoms just through changes in adolescent sleep duration. Now, there are some limitations to that research too, such as sleep quality and sleep disturbances are a symptom of mood disorders. So, the changes in sleep duration can be both a cause and a consequence of these changes in adolescent mood problems. But certainly, given the longstanding changes in the prevalence of sleep and the robust evidence that disruptions in sleep can disrupt mood, certainly the changes that we're seeing across the last 30 years in sleep duration can explain some of the increases we're seeing in adolescent mood problems. But we wanted to take a step back from even that, and we were kind of going through this research, kind of doing piecemeal, okay, what about this risk factor? Okay, what about this risk factor? What about that one? And we started to take a step back and think, we need to think about this differently. We need to think about how all adolescent, life and the way adolescents interact with each other and the activities that we're doing, it's all changing. And if we try to abstract each individual risk factor and say, okay, this one contributes 20% and this one contributes 30%, are we really getting a full picture of adolescent health? And so what we've been trying to work on instead is a quantitative way to define adolescent time use patterns. And so what we've done in the Monitoring the Future data is we've collected every single item in Monitoring the Future that measures some way that adolescents are spending their time. Now, this includes a whole range of different activities, such as, things like dating, going to parties, playing sports, going to movies, using social media, going to concerts, religious service attendance, everything that we've talked about before, doing your homework, watching television, reading periodicals, every single way that adolescents can be using their time. We took all of those data, harnessed together, and we did latent profile analysis to extract the groups of adolescents who do similar kinds of activities. and kind of extracted their correlation. And what we observed really, we kind of call this like the breakfast club analysis, because like you do this analysis and you abstract, like the kids that emerge are like, some of them like play sports, some of them study a lot, you kind of get these like traditional groups of adolescents. But essentially what we were able to converge on is that our data were robustly showing us that there were 6 groups of adolescents that we could reliably extract from these time use patterns. And they really corresponded to unsupervised time. How much of the time adolescents were engaging activities where they were not supervised by a parent or another caregiver or an adult of some kind. And so we called that UST, unsupervised time. And so you've got kids who have low unsupervised time and kids who have a high level of unsupervised time. That's what you see here in this graph. We also abstracted groups of kids who were doing a lot of theft and vandalism, groups of kids who were working a lot for pay, and groups of kids who were absent from school, skipping class, and that type of activity. But really the 3 most prevalent groups here, the yellow line, the blue line, and the red line, are correspond to how much unsupervised time adolescents are engaging in, and whether during that unsupervised time they're engaged in sports and other activities, or whether during that time they're doing nothing. They're doing nothing else. They're not really engaging in other activities. And what you can see is that there's been a fundamental shift in the prevalence of the membership of these groups. In particular, these 2 groups are extraordinarily increasing in prevalence, having low unsupervised time and being engaged in activities, and having low unsupervised time and not being engaged in activities. Essentially, adolescent unsupervised time is rapidly declining. Adolescents are highly, highly supervised. The major group that's declining in prevalence are adolescents who have a high level of unsupervised time. And not only are these group memberships changing, but this red group is really the risk group for depressive symptoms. Adolescents who have low unsupervised time and are not engaged in other activities to fill that time, such as sports, such as studying, and other activities like that. And we can see that when we take each decade of these time use groups and correlate them to depressive symptoms. Essentially, if you looked in the 1990s, the group that had low unsupervised time and high engagement had the lowest level of symptoms, and each group had a higher level of symptoms compared to that group. For example, the low unsupervised time, low engagement group had 2.5 times the probability of being in a high depressive symptom group. All of the groups are declining overall in their relationship to the low unsupervised time, high engagement group. And that's because the low supervised time, high engagement group, their depressive symptoms are increasing too. So all the groups are constricting together in terms of the prevalence of depressive symptoms because they're all increasing in their depressive symptoms. But still, robustly, it's this group of low unsupervised time, low engagement that's both increasing the most and has the most more reliable association with depressive symptoms. And so if you look at the contribution of each of these time use groups to depressive symptoms, what you can see is that in the early 1990s, the group that was contributing the most to depressive symptoms was kids who had a lot of unsupervised time. They were just not engaged in activities. They were not doing anything. They are declining in terms of their contribution to depressive symptoms. And it's these 2 groups, the low unsupervised time, low and high engagement, that is contributing the most to depressive symptoms in the United States. So that's where our research is going, but certainly we're looking at a whole range of other factors too that are important to point out. For example, in 2010, we had the Sandy Hook school shooting in which a number of children were shot by a young person in the United States. And that led off a litany of school shootings and increased school surveillance in the United States that continue to terrorize, essentially, the American school attending student. We had bereavement and loss from a extraordinary opioid overdose crisis, where we had 70,000 people die of overdoses, and those are mothers, fathers, aunts, and uncles of our American adolescents. We have climate and economic crises alongside a racial reckoning over police brutality and this rapidly divisive political environment, all of which are affecting adolescents. This is all coinciding with rapidly shifting substance use trends, both declining, things like alcohol, and vaping, which is increasing. And of course, COVID-19 is going to amplify and diminish some of these effects depending on, how that is associated with time use. So to conclude, I hope that, what's going on in the United States at least provides a lens for which to think about, how we might think about prevention and mental health differently. And essentially what we're seeing in the US is that mental health is undergoing a rapid change and signals an emerging crisis. We really don't know what's going on, what's underlying these trends. But what I've determined essentially is that this piecemeal research trying to pick at different risk factors is probably not productive overall, because adolescent lives and their time use patterns are rapidly changing. So engaging with a broader sociological framework may prove useful for these prevention and intervention initiatives. And with that, I'd really like to thank all of my collaborators who helped me with this work at Columbia, University of Michigan, and New York University, and my funding sources, which include the National Institute of Health and the Centers for Disease Control and Prevention. Thank you.
So can we all thank you very much, Kerry. That was an absolute storm of information and challenging information. It was fantastic. I know you can't see, and I know you can't see the audience, but I'm sure in their lounge rooms they are all clapping.
I believe it.
So thank you so much. And there are a lot of questions coming through. We do have 5 minutes for some questions. So if you're okay with that, I'll throw you some questions.
Sure. Yeah, of course.
Fantastic. So the first one coming through is, given the evidence on social media, and it's so true that everyone goes to social media as the reason that we're having these problems, given that evidence that maybe it isn't social media causing the problems, are there ways that we could actually use social media in prevention to help then?
That's a great question. And in fact, I've seen some research suggesting that delivery of mental health care through smartphone technology is the most acceptable in terms of what adolescent preferences are for receiving mental health care. And this is what was most problematic about this. For example, Silicon Valley in the United States, they released this open statement that they think that smartphones should be banned for people under 18. And there's been this whole movement to take phones away from adolescents, which is really potentially destructive if that is one of the best ways to deliver mental health care. So absolutely, I think that what's emerging, and especially you see it during COVID-19 when tele-delivered psychotherapy and psychiatry are rapidly expanding as treatment modalities. So I think smartphones really are a key to preserving adolescent mental health and intervening when those symptoms occur.
So using that power, thanks. I have another question, Kerry. You mentioned that there was a very strong relationship between unsupervised time and depression. The question is whether you looked at the relationship between unsupervised time and substance use in these adolescents.
Yeah, so that's what we're doing now, actually. And certainly what we've seen, we've been looking at just in a very crude way, these relationships with crime, adolescent conduct problems, theft and property damage and getting into fights. And it correlates quite strongly with the decline in the amount of unsupervised time that adolescents are spending with other adolescents, because it makes sense. If you're not spending any time unsupervised, like that's where drug and alcohol experimentation is most likely to occur, when you're hanging out alone without a parent with your friends. And so if that's declining, it might to some degree underlie the declines that we've been seeing in substance use, although a lot of those declines preceded when these changes in unsupervised time occurred. And certainly there's other substances that are taking the place of the kind of traditional substances that we saw in adolescence, like alcohol and tobacco use. And obviously, a key driver there is vaping. What's unique about vaping is that it's largely odorless. And so you don't have the same issues with using those substances when you're in a highly supervised environment that you would if you were using other drugs that you could smell and, notice your teen doing. So yes, that's our next step, is to look at those patterns with substance use.
Fascinating. And I think I can squeeze in one more question. The question says, thanks, Kerry, so interesting. I really have to agree with that. Any evidence that the change in trends in sleep may be related to increased social media screen time?
Yeah, that has been that hypothesis has been put forward as well, and we've tried to look at this a lot. And essentially, the biggest decreases that you saw in adolescent sleep and monitoring the future, at least, like this is just one data set, so take it with every grain of salt. But the biggest decreases were actually in the 90s. And you still saw some declines in sleep kind of in the post-smartphone era, but certainly not to the degree that you saw it from like 1995 to 2005. And what it correlates most highly with is pediatric obesity, which we know to be very disruptive of sleep. The trends in sleep map much more closely onto the fastness of the increase in pediatric obesity than to smartphone use. But that's not to say we know that using smartphones late at night is disruptive to adolescent sleep. So certainly not suggesting that smartphones are a panacea by any means, but certainly in terms of the trends we see, they correlate more broadly with these broader health patterns.
So I'm going to ask everyone to clap so loudly in their lounge rooms in Australia for you, Kerry. Thank you so much.
Thank you.
That was an amazing presentation. And I think you can stay online, and hoping that we can have some interactions. And I know there are a screen full of questions here, so we'll try to get to as many as possible.